Hello, this is Lucinda Ham, Senior Health Program Specialist for Missouri Cancer Registry and Research Center. Today's slides were created by Babette Langeneckert, Senior Data Coordinator and Education Coordinator. We are going to discuss surgery of primary site codes for 2023. Before we begin, I would like to acknowledge that Missouri Cancer Registry and Research Center is housed on the campus of the University of Missouri in Columbia, Missouri. The Missouri Cancer Registry and Research Center is supported in part by a cooperative agreement between the Centers for Disease Control and the Missouri Department of Health and Senior Services, and is a surveillance contract between DHSS and the University of Missouri. Missouri is also a research state for SEER. In this presentation, you will learn about the basics of coding surgery and site-specific review for bladder, lung, and melanoma cases. Coding surgery, the basics. The first course treatment includes all methods of treatment recorded in the treatment plan and administered to the patient before disease progression or recurrence. Timing when no treatment is documented. If there is no treatment plan and consultation with a physician advisor is not possible, use the principle initial treatment must begin within 1 year of the date of diagnosis. Disease progression. If surgery of the primary site was not performed because of disease progression, then code the reason for the surgery of primary site as contraindicated. Code from the operative report. Code the treatment that was given, not the results of the treatment. And remember that surgery codes are cumulative. When multiple surgeries are performed, the most extensive or definitive is the last performed, and the code represents the cumulative effect of separate procedures. Surgery of primary site resources. Surgery of primary site codes are site-specific and may differ based on diagnosis year. Use the appropriate manual based on the diagnosis year. The link on the screen shows a link to the store manual where you can pull up the various years. Let's compare the surgery codes prior to 2023 with the new surgery codes with 2023 going forward. As you can see, the old surgery codes from 2003 to 2022 were only 2 digits. Beginning with 2023, the surgery codes will now be 4 digits. Fortunately, there is some consistency in the codes where an A and a 0 were added at the beginning and at the end of each code. Let's review an example of the surgery code changes. For example, a patient with breast cancer had a modified radical mastectomy of her right breast. If we were coding this case and the patient was diagnosed in 2022, the appropriate code assigned would be 51. For 2023, the appropriate code assignment would be A510. With 2024, because there were some major changes, the appropriate code assigned is going to be B610. Surgery codes are in hierarchical order. On 2/11/22, a patient presented for a transurethral resection of a large bladder tumor, or TURBT. The operative report states, using a loop electrode, a resection of the bladder tumor was performed all the way up to the base. The tumor base was then cauterized to stop the bleeding. So in this instance, we would look at Appendix A of STOR 2022 because it was a 2022 case, and the code for the primary site is 22 electrocautery. Let's look at another example of coding surgical procedures of the primary site. On 2/15/2023, a patient was found to have a small mass in her left breast and presented for a biopsy. The operative report stated she had a needle-guided core biopsy. The pathology report revealed ductal carcinoma. The patient returned a week later for surgery, where she had a lumpectomy performed. The pathology report revealed no residual tumor. How is the first procedure coded? It should be coded as 02 biopsy to the primary site. How is the second procedure coded? Use Appendix A of STOR 2023 because this is a 2023 case, and code the surgery primary site as A220 lumpectomy excisional biopsy. Code the procedure. Scope of regional lymph node surgery. Patient with biopsy-confirmed breast cancer presents for sentinel lymph node biopsy. 4 lymph nodes were removed, but the procedure failed to identify any sentinel lymph nodes. So how would you code this? Code the scope of regional lymph node surgeries. Number 2, sentinel lymph node biopsy. Code the procedure and not the results, even though no sentinel nodes were identified. Coding multiple procedures. In example 1, a patient with stage 2 breast cancer had a lumpectomy on 2/12/23. Pathology showed positive margins. The patient returned on 3/2 of 23 for re-excision of the margins. Assign the first procedure as A220 lumpectomy and the second procedure as A230 re-excision of the biopsy site. In example 2, the patient also had a lumpectomy. At the time of the lumpectomy surgery, a pathologist reviewed the slide and determines that the patient has positive margins. During the same procedure, which is the lumpectomy procedure, a re-excision of the lumpectomy cavity is completed. Assign code A220. Only one procedure is coded in this instance. Scope of regional lymph node surgery. If 2 or more surgical procedures of regional lymph nodes are performed, the codes entered in the registry for each subsequent procedure must include the cumulative effect of all preceding procedures. See STOR 2023, page 233. For example, a sentinel lymph node biopsy followed by a regional lymph node dissection at a later time is coded 7. Surgery codes are cumulative. For example, a patient was diagnosed with a large nodule in his thyroid in 2018. A right lobectomy was performed. The nodule was found to be benign. The patient returned in 2023 and was found to have multiple nodules in the left lobe of the thyroid. The left lobe and isthmus were removed. The nodule was found to be papillary follicular carcinoma. What is the surgery of the primary site? Use Appendix A of STOR 2023. Code the surgery primary site as A500 total thyroidectomy. If a previous surgical procedure to remove a portion of the primary site is followed by surgery to remove the remainder of the primary site, then code the total or final results. Do not rely on registry software to perform this task for you. Now we will code some bladder surgery cases. Bladder Case 1. On 1/18/23, a patient presented for a TURBT. The path report revealed papillary urothelial carcinoma, high grade, no invasion of the lamina propria. On 2/1/23, the patient had intravesical BCG for 6 weeks. On 3/22/23, another TURBT was performed with no evidence of carcinoma. So if you look at the graph on 1/18/23, the surgery, the primary site would be A270 excisional biopsy with no regional lymph node surgery. And then again on 3/22/23, the code would be A270 excisional biopsy with no regional lymph node surgery. Note that the 2/1/23 BCG immunotherapy was followed by a surgical procedure in the A200 to A800 range. Only code the BCG in the immunotherapy field. Let's look at another bladder case. On 4/12/23, a patient presented with a history of frequency, urgency, and incomplete emptying of the bladder. On 4/18/23, a CT scan of the abdomen and pelvis was performed, which revealed a mass in the bladder dome with apparent extension into the outer layers of the bladder wall muscle. There was no adenopathy. On 4/25/23, a TURBT was performed, which revealed a 4.5 centimeter tumor in the dome. It was partially resected deep into muscle at the base for staging purposes. Bleeding was controlled with fulguration. The path report revealed high-grade invasive sarcomatoid urothelial carcinoma invading the detrusor muscle. So how would you code this procedure? It would be coded to A270 excisional biopsy. Because the patient had potential for residual disease, on 5/14/23, a segmental resection of the dome of the bladder and bilateral pelvic lymph node dissection was performed. The pelvic lymph nodes were found to be grossly normal, and no extension of the tumor was found into the serosa or perivesical fat. The path report from 5/14/23 revealed 0 out of 3 right and 0 out of 4 left obturator lymph nodes positive. The bladder tumor was a low-grade invasive urothelial carcinoma with a transmural invasion of pericystic fat. No extension was found into the serosa. There was extensive small vessel and perineural invasion. The margins were free. The plan was to refer the patient to a medical oncologist. So how would we code this case? It would be A300 for partial cystectomy, and the scope of regional lymph node surgery would be a 5 for 4 or more regional lymph nodes removed. Now let's see how we code lung surgery cases. Lung Case 1. On 12/29/22, a CT of the chest revealed 2 ground glass nodules, one in the right upper lobe and one in the right lower lobe. On 4/19/23, a PET scan was suspicious for a lung malignancy. On 9/12/23, the CT of the chest showed a 1.7 centimeter ground glass nodule in the posterior right upper lobe and a 1.3 centimeter ground glass nodule in the superior segment of the right lower lobe. Both were concerning for malignancy. On 10/22/23, right upper lobe and right lower lobe wedge resections were performed. The path report revealed an invasive, well-differentiated adenocarcinoma with a predominant lipidic pattern in the right upper lobe 2.2 centimeter lesion and in the right lower lobe 1.2 centimeter lesion. No visceral pleural invasion was identified. LVI was negative, surgical margins were negative, and the 2 peribronchial lymph nodes were also negative. So, how would we code this case? We would code the surgery, the primary site, to A210 for a wedge resection, and the scope of regional lymph node surgery would be 4 for 1 to 3 lymph nodes being removed. Because the patient had two primaries, the surgical code for each will be A210 wedge resection. Let's look at another lung case. In case 2, a chest x-ray was performed on 8/31/23. It showed a 2.5 centimeter circumscribed mass in the left lower lobe. On 9/4/23, a mediastinoscopy was performed. There was no evidence of enlarged lymph nodes. On 9/4/23, a left lower lobe lobectomy was also performed. The tumor was intimately attached to the pleura but appeared to be completely resected. The path report revealed a 2.5 centimeter moderately differentiated adenocarcinoma with invasion of the visceral pleura. 0 out of 5 hilar lymph nodes were positive. The surgery code for this site would be A300 lobectomy. The scope of regional lymph node surgery would be a 5 for 4 more regional lymph nodes being removed. However, no mediastinal lymph nodes were removed in the resection, only hilar nodes, so surgery does not qualify for code A330 lobectomy with a mediastinal node dissection. Let's look at how to code melanoma surgery cases. Melanoma case 1. On 7/14/23, the patient had a shave biopsy of the left nasolabial fold. On 7/21/23, Mohs excision of the left nasolabial fold, layer 1, was performed. The entire gross specimen with 5 mm margins was excised to the subcutaneous plane. On 7/24/23, Mohs excision of the left nasolabial fold, layer 2, was performed with re-excision with an additional 3 mm margins to the subcutaneous plane. So how would you code this? On 7/14/23, the surgery primary site code would be B220 for the shave biopsy. On 7/21/23, the surgery primary site code would be B320, Mohs surgeries on different days. And on 7/24/23, you would not code that procedure as it's included in the 7/21/23 procedure. Please note that starting in 2023, clinical margin width is collected separately as a site-specific data item. Code the peripheral surgical margins from the operative report from the wide excision. When there's no wide excision, use code XX.9. Melanoma case 2. On 7/29/23, this patient had a shave biopsy of the mid-abdomen. The path report revealed malignant melanoma, 9 millimeters thick, with a mitotic rate of 13, positive ulceration, and no regression. On 8/19/23, a PET scan was performed, which showed positive bilateral axillary lymphadenopathy, suspicious for malignancy. On 8/27/23, a left axillary ultrasound-guided core needle biopsy was performed. The path report revealed metastatic melanoma. On 9/29/23, neoadjuvant immunotherapy with Keytruda was started. So how would you code these procedures? On 7/29/23, the surgery of primary site is going to be B220 for shave biopsy. On 8/27/23, the surgery of primary site code is going to be A000 for no procedure. The scope of regional lymph node surgery is going to be 1 for FNA biopsy of the axillary lymph node. The clinical margin width is going to be XX.9 as no wide excision was performed. Continuing on with case 2, on 11/25/23, the patient returned for a mid-abdomen wide re-excision. The path report revealed scar tissue secondary to previous procedure with no residual melanoma. A left axillary level 1 through 3 lymph node dissection was performed, which revealed 1 out of 17 lymph nodes showing necrotic tumor, consistent with metastatic melanoma with therapeutic effect. The right axillary level 1 through 3 lymph node dissection showed all 18 lymph nodes as being negative. So how would you code this surgical procedure of the primary site? Code B520, shave biopsy followed by wide excision. Note that a wide excision was performed, but clinical margin was not documented, so use code XX9 for clinical margin width. Melanoma case 3. On 6/1/23, patient presents with a 1 mm nodule on the left forearm. A punch biopsy of the left forearm was done, which showed residual malignant melanoma left at the margins. The path report showed a 1.2 mm malignant melanoma. So how would you code this procedure? Code it as B230 punch biopsy. Clinical margin width would be coded to XX.9 as no wide excision was performed. Continuing on with case 3, on 6/25/23, the patient returned for wide local excision of the lesion of the left forearm. 2.5 centimeter clinical margins were taken and a sentinel lymph node biopsy. Due to the positive sentinel lymph node on frozen section, an axillary lymph node dissection was performed. 2.5 centimeter peripheral margins were obtained. The path report revealed a 1.3 centimeter residual melanoma, margins negative by 2.1 centimeters. 1 out of 3 sentinel lymph nodes were positive. 0 out of 7 axillary lymph nodes were positive. So this procedure would be coded as B530 punch biopsy followed by wide excision. The scope of regional lymph node surgery would be 6 for sentinel lymph node biopsy and axillary lymph node dissection at the same time. The clinical margin width is 2.5 and the clinical margin width is taken from the operative report. If you have any questions, please call MCR's helpline at 1-800-392-2829. The resources used for this presentation are: Number 1, NACER webinar, Breast 2022, Part 2, presented November 2022. Number 2, NACER webinar, V23 updates, presented in January 2023. Number 3, the MPCR ETC webinar, RX summary primary site, RX regional lymph node summary, presented in July of 2023. And then STORE 2023. Thank you.